Introduce Dr. Sandra Hassink, who is a past president of the National AAP, and she is the director of the AAP's Institute for Healthy Weight. And she is here to speak to us for 2 sessions today. And her first one is on obesity prevention. What do we do for infants under 2? So without further delay, I will turn it over to Dr. Hassink. Good morning.
Good morning, Katrina. Can everybody hear me? Just nod. Katrina, can you hear me? Okay, great. Well, I'm so happy to be here with you today. And let me see if I can get my slideshow up here. So today we're going to talk about obesity prevention. And the question really is, what do we do for infants under 2 years of age? Okay. And I'm having trouble sharing my dancing here, so hang on.
Dr. Hassink, you can hit the right arrow key on your keyboard to navigate the slides.
Yep, doing that. Not happening. Let me go back.
Dr. Hassink, make sure you click on the slide and then try hitting the arrows.
Okay, thank you. Yes, so I have nothing to disclose. And today we're going to understand, try to understand the evidence-based risk factors for obesity in infants, the role of parenting practices, community factors that impact infant obesity risk, and get ready for the Infant Feeding Collaborative Healthy Beginnings. So when we think about nutrition, it's seated in context of the foundations of health for children. And so appropriate nutrition, nurturing relationships, supportive environments all connect to make it better, a better foundation for health of our children. So nutrition is right in the bullseye of those foundations. And we know that nutrition is linked to chronic disease. And I think this is becoming more and more apparent as we've seen the obesity epidemic unfold. And there is a clear relationship between poor nutrition and chronic illness, both in childhood and in adulthood. And as Healthy People has rolled out, they are promoting good nutrition as a major preventive effort for chronic disease in this country. We also know that the prevalence of obesity escalates by age, and you can see here our 0 to 2-year-olds, 2 to 5-year-olds, 6 to 11-year-olds, 12 to 19-year-olds, and we see the big jump into our young adult ages. So the opportunity here is for pediatricians to intervene early as possible, and that's why we're here today. We know that our obesity rates are still climbing. We saw a dip in our 2 to 5-year-olds around 2012. We were celebrating that, and then we saw that rise again. So we're not getting as much traction on obesity as we had hoped. We also know that severe obesity is not uncommon in our 2 to 4-year-olds. And so you see the rates of severe obesity. Now, these are small rates, but when we think of severe obesity, this is what brings on early comorbidities of obesity. So we see severe obesity already in 2, 3, and 4-year-old children. Now we know that there are many risk factors for obesity in our young children, and you can see here that they occur at the level of the infant, the family, and the community. And the risk factors are in red, and just as just taking a snapshot of this, and the protective factors are in green. And we see that right now we have a lot more risk in the environment of our young children than we do protective factors. And we'll be talking about a lot of these later. Now, one concept I want to really convey is that prevention is cumulative. We know that. We say our preventive messages and anticipatory guidance throughout childhood, but with obesity, this is particularly important. And what we do is we want to know that parents are thinking about feeding earlier than maybe we anticipate, and also they may not be thinking about feeding and be just rolling into normal feeding practices that exist in their family. So when we think about early infant obesity, we want to start with a healthy pregnancy, and you can see here the factors that accumulate really in the mom to create a healthy or unhealthy pregnancy. We know that families with one or both parents who have obesity are at increased risk for having a child with obesity. So we already know in many of our families there's already a genetic and environmental risk for our children. So starting early is imperative. We also know that many of our women in their prime reproductive ages have elevated BMIs, over 1/3 of them. And our non-Hispanic white women, 31.3% have a BMI over 30. Our Black women, 47.2%. Our Hispanic women, 37.6%. And 18% of women 20 to 39 have a BMI over 35, and 4% have a BMI over 40. And so almost 20% of women have a BMI where surgery might be considered for obesity. And we know that newborns of mothers with obesity are different. They have increased fat mass and insulin resistance. And the degree of insulin resistance in that newborn correlates with the maternal infant resistance, insulin resistance, and infant adiposity. So we have a role to play here, both in caring for our newborns, but also caring for our adolescent girls as they approach their reproductive ages and try to get them help them be as healthy as possible. We know that maternal gestational weight gain has come under scrutiny. There are guidelines now for the appropriate amount of weight that a mom can gain, and we know that 9-year-old children of mothers who had increased gestational weight gain have an increased BMI, waist circumference, fat mass, blood pressure, inflammatory markers, and lower HDL cholesterol and apoprotein 1 levels. So these effects in pregnancy are long-lasting. We know that mothers who had both overweight and gestational diabetes, that's an increased risk for their children to have overweight, and that we hope that adequate treatment of gestational diabetes during pregnancy may attenuate this risk. And in fact, in England, they do glucose tolerance tests on all women who have obesity in pregnancy to try to find gestational diabetes early and treat it. As we move into the perinatal and early newborn period, we have a couple of really targeted areas for intervention, and you can see them here. We know the importance of maternal mental health, and so the feeding dyad, the mother and infant feeding dyad, is incredibly important. But mothers who reported more depressive symptoms in the prenatal period had less positive parenting during infancy, lower levels of child self-regulation as a toddler, and a higher child BMI at 36 months of age. So maternal mental health, because mother is such an important part of that feeding dyad, is incredibly important. And that's why we screen for maternal depression, among other things. Breastfeeding and obesity, there is a protective effect of breastfeeding. Duration is important. The longer you can breastfeed, the more your risk of obesity is reduced. Now, that's not to say that a breastfed child will not have obesity, but it is one protective factor that you can put into that equation. Exclusivity is important. So exclusive breastfeeding for 4 months had a smaller rate of increase of weight per length percentiles during the first year of infants. And again, formula-fed infants tend to have a different kind of body composition. They often have increased fat mass. So breastfeeding is a crucial obesity prevention strategy. Breastfeeding intention is a significant predictor of initiation and duration. So mothers often make up their mind to breastfeed or not early in pregnancy. And mothers who are non-Hispanic white, non-Hispanic Black, and Hispanic who perceived that the baby's father or the grandmother preferred exclusive breastfeeding were more likely to breastfeed. So this decision involves the extended family oftentimes. And that decision really is a predictor of if they will breastfeed and how long they will breastfeed. Now we know that we have gaps in our breastfeeding around poverty and race and ethnicity. So we know that the poorer you are, the less likely you are to ever breastfeed, and the less likely you are to continue to breastfeed, and that's the graph on your left. And on the right, we know that non-Hispanic Black mothers are less likely to initiate and sustain breastfeeding. So we have gaps here that need to be addressed. And of course, obesity is associated with poverty and minority status. So that these breastfeeding is even more crucial to initiate and sustain in these populations. Now, in surveys of parents, 92% of mothers report feeding problems on day 3 postpartum. And so we have critical periods here for breastfeeding continuation. So while 80% of mothers expect to breastfeed, national data indicates that only 41% are exclusively breastfeeding at 3 months, and only 19% are exclusively breastfeeding at 6 months. So we have good intent, but getting those early problems resolved are really important for breastfeeding continuation. Between 2 to 3 days and 1 month, women will often stop breastfeeding over concerns around having enough milk, challenges with transitioning and getting home and breastfeeding at home, lack of confidence in breastfeeding, pain, or lack of sleep. So these are areas that when you see the mom's back, you should be keyed into. Mothers in general all know breastfeeding is good, support it, but know that there are challenges, and you have to help the mom individualize for her situation in addressing these challenges. At 2 months is the second critical period when women stop breastfeeding, and these may be just psychosocial issues, stress, depression. Sometimes they feel they've met the critical period of breastfeeding in terms of immunity or other benefits, and it's okay to stop. The third critical period is really the transition back to work, which can be the most critical transition to deal with, and problematic in some areas where the workspace is not as friendly to breastfeeding. 27 pediatricians have a lactation consultant in their practice, and I think those that do have found it extremely beneficial, because parents may not be aware of all the benefits of breastfeeding. It has important, as we all know, short and long-term benefits, but parents may not know that these benefits last through childhood. They reduce breast cancer risk, they promote bonding and strengthen the immune system, which are additional benefits. Parents have a harder time understanding the benefits of breastfeeding for obesity. It's harder in our studies of parents for them to appreciate that obesity risk until the child starts eating solid food. So that's an area I think we have some education we could do. The breastfeeding, the parent perspective is parents have concern about getting the baby enough nutrition and milk supply. It's a personal and cultural decision. If it doesn't go well, they can be feelings of guilt and failure, and the connection between breastfeeding and obesity is not that well known. So these are just things that you see the mom over there saying it's harder than I expected, and just to understand that and help her tailor her breastfeeding support to her situation. So when you're thinking about breastfeeding success, education of the staff is important, knowing available breastfeeding supports in the community. Lactation consultants can be crucial here, knowing the rare but true contraindications to breastfeeding, supporting your baby-friendly hospitals, and knowing what your breastfeeding rates are in your practice, so that you can pay attention and see if you can move that dial on the breastfeeding rates. Now, bottle feeding, infants, of course, are frequently bottle fed in early infancy, and their feeding patterns are different. They're more likely to empty milk from a bottle or cup in late infancy. The formula bottle feeding, that mechanism of the bottle, possibly has an effect on feeding self-regulation. In early infancy, the total energy intake and the sucking behavior of an infant, rather than energy expenditure, has the most influence over body weight. So that sucking behavior and intake is really what drives early infant weight gain. And then mixed breast and formula feeding is associated with higher weight and length for age at 3 to 6 months, 6 to 9 months, and 9 to 12 months. And so mixed feeding is often common and bumps that obesity risk up. Other feeding related risk factors are feeding to schedule has also been linked to early weight gain. And so higher volume feedings, higher daily volumes of formula fed infants, lower frequency and longer interval between feedings have all been linked to early weight gain. And these things can be mitigated, and we'll talk about responsive feeding in a minute, how you can mitigate some of this. Parents often believe that formula is a solution to getting the baby to gain more weight. Younger mothers and low-income mothers are more likely to offer a bottle to soothe the baby. 50% of mothers have not been given any instructions on bottle hygiene and feeding techniques. And in research, it shows that when researchers have asked moms to bring in the bottle and the formula and mix the formula in clinic, the calorie counts have varied anywhere from 5 calories an ounce to 50. They often don't understand how that goes. And cereal, of course, can be introduced as early as 2 to 3 months, and cereal is a carbohydrate and adds to the caloric intake of the baby. So parents may offer a bottle to get the infants to sleep, and so you're often giving sleep advice along with your advice around feeding. And Hispanic populations do frequently use breast and bottle feeding in conjunction, and that's called Los Dos. So proper bottle feeding can lead to better health outcomes, and this is where learning hunger and satiety cues becomes very important, so the parents can tailor feedings, and we'll talk about that in a minute. Holding an infant during bottle feeding allows for responsive feeding, and over and under feeding can be avoided by proper mixing of formula. So those are some points to help the parents. So as we move into early infancy, and you'll see lots of these subjects are repeated, right, throughout early infancy. That's because these messages are important. Different ways of challenges around these feeding modalities occur at different ages, and you'll find yourself repeating the topics, but the advice being tailored to the age of the child and the situation of the feeding dyad. So transitions, again, are critical for maintaining breastfeeding, and you see that last one, return to work, can often be the most critical in not continuing breastfeeding. Infant feeding choices really are more about how women were able to fit feeding into their daily context of their lives than a commitment to breast or bottle feeding. Many women feel breastfeeding is important, but can't fit it into that transition that they're experiencing, for example, returning to work. And that's where you can help mom tailor what's going on there. And so just point you to an app that we've developed called Change Talk. And we've added to this a module on breastfeeding continuation, and it's around motivational interviewing. It's free. You can get it in your app store, and you can move through that module and really work out a motivational interviewing approach to a mom continuing breastfeeding. And there were 2 other scenarios there, an older boy with overweight, and a little toddler who's hungry all the time. So why responsive feeding? So caregivers and infants interact through feeding, and it's the child's first most powerful need. And this is where the nurturing relationship and the nutrition come together. So responsive feeding is associated with healthy feeding patterns, food acceptance, and healthy food habits. And it supports self-regulation skills, very important for later on. And parents who practice responsive feeding will have children who have healthier eating habits. And so what happens here is the infant signals hunger or satiety. The caregiver recognizes the cues and responds promptly, and the child experiences a predictable response to their signals. So here you see early, mid, and late feeding cues. And so parents may not recognize that a stirring infant, opening their mouth or turning their head, that infant is getting ready to eat. They may wait until the infant's stretching, scooching around, putting their hands in their mouth, or they may even wait till the infant is crying, agitated, or turning red. And so you want to cue the parents into these early feeding cues so they can get that responsive cycle going without the infant progressing all the way to agitation. So this is the position we all know that's important, that eye contact, the holding the baby, holding the bottle, and that responsive position of the mother and baby. So the next thing that parents often are dealing with are juice. So 80% of 6-month-olds have already been introduced to juice. And we have a juice statement from the AAP that really says quite clearly, human milk or infant formula is sufficient for infants, and low-fat or non-fat milk and water are sufficient for older children. We want our children to be eating their fruit, not drinking their fruit, and we support policies that seek to reduce fruit juice consumption and promote fresh fruit. And fruit juice, again, very clearly stated, offers no nutritional benefit to children under 1 and should not be introduced to their diet. And you can see at the bottom there that the intake of juice should be limited to at most 4 ounces a day for toddlers, 4 to 6 ounces for 4 to 6-year-olds, and 8 ounces for 7 to 18-year-olds. So it's very clear here that we want to limit juice. This is not a message that many parents are getting through advertising or the media. Although we've seen a small reduction in sugar-sweetened beverage consumption in the population, little children are still drinking sugar-sweetened beverages. So children who consume sugar-sweetened beverages during infancy had a higher rate of obesity at 6 years, okay? So the 71% higher for any sugar-sweetened beverage intake, 92% higher risk of obesity for sugar-sweetened beverages before 6 months. So, and also higher odds of obesity in children who consume more than sugar-sweetened beverages more than 3 times a week than between 10 and 12 months. So not only is juice not necessary, but infants are drinking sugar-sweetened beverages, and that has to be an important point of counseling. So understanding healthy beverages, often parents are more motivated by the immediate impact on oral health than they are on obesity, and that's just fine. They think 100% juice is healthy, but don't understand they should limit it. And flavored fruit drinks are confusing and often can appear as healthy beverages. And this is, again, something that parents need to be advised on. And oral health, again, may be a good point to make. So as early as you can, begin discussing appropriate healthy beverages. Remind parents, of course, no bottle to bed. Unhealthy beverages add calories, and parents often think that the children drank it, so they're not as keyed into energy intake with the beverages they are to solid foods, and the child drinks what the family drinks. So if it's at home, that child will roll into drinking that. 4 in 10 parents introduce babies to solid foods before 4 months. Again, early introduction of solids, especially if the infant is fussy. Formula-fed infants are more at risk for early introduction of solids. And at 4 months of age, infants at early introduction of complementary food were more likely to have discontinued breastfeeding. So often breastfeeding stops when solid food is introduced, and intakes of sugary or fatty foods at 12 months. So early introduction of solids drives feeding behaviors that you don't really want to have. And early introduction of solids among formula-fed infants is associated with a higher BMI. So we really want to, again, start as early as possible to talk about when solids should be introduced. By 6 months, the deed may be done. So we want to start in those early visits to talk about early introduction of solids. And here you see mothers often stop breastfeeding once solids are introduced. Sleep drives a lot of parental behavior. It's a crucial need, obviously. And so evidence has suggested there's a decrease in sleep duration across infancy and early childhood. And so kids are sleeping less. Starting at 3 months, we should start to think about good sleep hygiene. And the parents, although you can understand that infants should get between 9 and 12 hours of sleep at night, sometimes that's really hard to achieve. And so sleep hygiene and sleep counseling are really important here. And naps are also really important. So I think there's no parent alive that doesn't want more sleep. And this can often drive feeding behavior as well, the need for sleep. There is some data that show maternal full-time employment was associated with a higher child BMI, but this is actually mediated by sleep, by hours of sleep, not by other daily routines. And so parents are often waking the children up early when they have to go to work. They may be keeping them up to just interact with them, but each extra hour of sleep was associated with a decrease of BMI percentage by 6.4% a year later in this study. So when you have a mom working, you really need to talk about how you get enough sleep, how you arrange family routines to optimize whatever they can do to get sleep and good feeding patterns. So early food introduction is associated with childhood obesity, but we need to also think about introducing a variety of textures and flavors at an appropriate time. You don't want to, so that it can set the stage for healthy eating patterns later on. So children live in a different taste world than do adults. So infant sensory systems detect and prefer sweet or salty foods, and they'll reject foods that taste a little bit bitter. So, and when children are growing, they prefer sweet and saltier solutions. So it's normal. But often parents are confronted with these pictures. They offer the child a new food, and you get the brow lower or the inner brow raise, squinting, nose wrinkling, gaping, make an upper lip raise. So parents introducing a child and getting this reaction are likely to back off and not introduce that food to the child again. So parents need to know that these looks are common, and they should be focused on their infant's willingness to eat food, not just facial expressions made during eating. And so sometimes the kid may be eating the food and still squinting or wrinkling their nose, but they will be eating it. So just a point to consider, because if you see these faces, you'll often just go, wow, the kid doesn't like it, and I'm not going to offer it again. Meanwhile, we need that variety in the diet to sustain a healthy, balanced diet later on. Parents often think, and in their desperation to get sleep, that solid food will help them sleep longer, and it doesn't. The introduction of a food 10 to 15 times is confusing because parents don't want to waste food. And a child who rejects food once, often the parent just backs completely away. So these, you have to just be aware of this and help the parent through this period. One thing that I'm not sure anybody understands is portion size. So toddler portion sizes, infant portion sizes are very small. So you can have vegetables, a tablespoon, fruit, a tablespoon, meat, a tablespoon. These are small portions. So parents often benefit by having posters or looking at pictures about what really is an infant serving size. Our adult portion sizes have increased to the degree that this seems minuscule because our own portions have so increased. Unhealthy snacking, often starts very early. And behaviors associated with later overweight include continuous snacking, consumption of non-nutritive snacks, double snacks. So snacking is a behavior you want to also counsel about. And we'll talk about that later. As we progress into the later part of the first year, you see that now feeding practices, self-feeding, beverages, maintaining variety in your diet, role modeling, activity time, all continue to be really important and expand. The repertoire of the infant and expands, and the counseling has to expand too. So young children are sedentary anywhere from 32 to 56 minutes per hour. That's a lot of sedentary time. And those early patterns can persist. So counseling around tummy time and activity are really important. Parents are largely unaware of the importance of unrestricted movement and its importance in developing motor skills and promoting appropriate physical development and expending energy. And they need to be sort of keyed into the fact that the movement and development go together. And infants who spend too much time in confining equipment may experience delayed motor skill development. And I think this is a big driver for parents who want their child to develop. So they may not be keyed into good activity patterns for later on or obesity prevention, but they sure are keyed into good motor development for their children. So counseling about this is important, but also around safety issues, parents' perspectives around what is safe. Activity time is time to bond. Role modeling is really important. And they all want to know about play. What can I do to get my child active? They all are open to ideas in our research about play and strategies for playtime. TV, and this we can include, this is data on TV, but screen times are up there too. 30% of 7-month-olds are watching TV on a daily basis. By age 1, 16% of kids have a TV in their room and have been exposed to mobile devices. One reason for putting a TV in a room, a big one, is parents see it as a sleep aid. Often when they're transitioning a kid from a crib to a toddler bed, that TV goes in that room, and many families have the TV on all day long. So we know this can disrupt play and activity levels and displaces reading time and often language development. And so 17% of infants under 1 spend an average of 1 hour a day watching TV. 25% between 12 and 23 months watch an average of 3 hours a day, and 30% of under 3s have a TV in their bedroom. And so children who have TVs in their bedroom are more likely to have overweight, have poor sleep hygiene, and be depressed. So once that TV gets in there, really hard to get it out, so it's important to really ramp up your counseling about that. Parents frequently view TV as an educational tool. It gives them downtime. The AAP recommendation of no TV or screen time for children younger than 18 to 24 months does not often fit with their personal experience, and they're often surprised that excessive media use has been associated with obesity, lack of sleep, school problems, aggression, and other behavior issues. So this is not something that you push on a parent, but I think just understanding why they feel TV is important, what they might do instead of watching TV can be very helpful here. So offer resources like the family media template to problem solve with the parent about how they reduce media intake and what creative activity ideas maybe will work instead. So by 9 months, food patterns are set. You can see that blue arrow down there. The children eat what their parents eat, and they start early, and they eat very few vegetables, mostly potatoes, and consume fruit drinks. So that you have to get this early. When they transition to family food, what the family is eating becomes critical, and the family then needs to modify that. So 43% of 9 to 12-year-olds consume desserts, sweets, or sweetened beverages daily, and that's a point. And the reason we're transitioning through these topics like this is how it goes with parents. You reiterate these at different ages. So you're going to talk about sleep again at 12 months. Toddlers, again, there's an association in early infancy between short sleep and increased weight, and the risk of overweight increases as more risk factors are added. So if the mother smoked during pregnancy, had some increased weight gain, shortened breastfeeding, decreased infant sleep, that escalates the risk of obesity. So these are topics that parents are concerned about all through those first 2 years. Now the child's world widens. They have more activities, more exposure to food, more exposure to other caregivers, and so their exposure to risk factors also can escalate. Again, sleep, sugar-sweetened beverages, fast food, TV set in the room are all clustered often in the same child and can escalate obesity risk. So if you find one risk for obesity, you often find more in a cluster. Again, portion sizes are an issue all through childhood. This is just an example of a toddler serving size. Again, often surprising to parents how small it is. Larger meal sizes at 21 months were associated with a greater weight gain from 2 to 5 years. And so for every additional 10 calories consumed per meal, the child's growth rate was 4% above average. And the odds of being overweight were 6% greater. So meal size is a critical driver of overweight in childhood. And many parents don't have good benchmarks for what appropriate portion sizes are. Again, reminding parents that what they eat is what their child is likely to eat. And this is just to show you feeding safety is really important, and information that you all have should be available to parents. Again, we're thinking about toddler TV. Parents at the toddler age just want the toddler to be less active. Toddlers are normally active. It's a normal stage of behavior, but when you interview parents, they want to know how can the kid be less active, and TV is often a way to get there. They often feel the value of education for TV, and many parents believe that educational television is very important for healthy development. And if they believe that, they're more than twice as likely to have the TV on all the time. children under 5, by and large, fail to meet physical activity guidelines. And even as young as 1 to 2 years old, children should be active at least 30 minutes of structured activity and 60 minutes and up to several hours of unstructured play. They play episodically. They should have opportunities throughout the whole day. They often do not because they're in restricted situations. And concerning behaviors, how long people are using strollers. So a stroller is not what you want to be seeing with your 5-year-old sitting in a stroller with the drink in the cup holder. It really impacts toddler activity. Again, beverages, flavored milk now comes in as a sweetened beverages in use. The top 5 energy sources for the 2-year-old age group are whole milk, fruit juice, reduced fat milk, and pasta. Clearly, work to be done here in this cluster of foods that's not as nutrition laden as we would like and provides a lot of extra energy. Snacking, you have a master list of toddler snacks here. 25% of 2-year-olds do not eat any vegetables. If they do, most of them are eating potatoes. Half of all snacking calories are from high energy snacks, high in solid fats and added sugars. Most children are consuming some kind of sweet every day, and including dessert. Many parents seem to associate snack times with treats. We tend to avoid that word treat around food because it implies a reward, and finger foods are usually prepackaged and often higher in calories, and parents like them because they are marketed as convenient, easy, and less of a choking risk, but still provide a higher calories than homemade finger foods. And snacking can be, on the other hand, an opportunity to get more critical nutrients in front of the child instead of more energy-dense foods. So the message here is snacks are real food, have a balance of nutrients, should be eaten at a table and in the presence of an adult. They're not mini meals or a time for treats or to be eaten all day long. And they should add to the overall nutrition of the child. So some key takeaways here are you are trusted as a source of information by parents, and you have opportunities here to really help parents get a grip on obesity prevention, early healthy nutrition and activity. Early feeding practices absolutely provide a critical role in the adoption of healthy active living behaviors. And there are key developmental windows where you can support these behaviors, and they come early. And so the idea of early and cumulative prevention is key. And risk patterns can also begin early, and negative health behaviors can begin early, and they inform the timing and content of your anticipatory guidance. Now, I just want to spend the next minute or two on what about the under 2-year-old with the elevated weight for length. So there's no accepted definition for obesity in children under 2, but children with a weight for length over the 95th percentile and children crossing percentiles are of concern. We should be using the WHO weight for length charts to identify children at risk. And what's the risk? The risk is rapid weight gain during infancy. It's consistently associated with obesity risk. Risk for metabolic syndrome is predicted by rapid weight gain during the first 6 months. And children who had a weight for length over the 95th percentile at 24 months had a high likelihood of having a weight for length percentile at 6 months. Infants with obesity at 24 months increased their mean weight for length percentile between the ages of 6 and 24 months, while healthy weight infants were decreasing their mean weight for length percentile. So the weight gain patterns of infants are crucial. Measure and chart weight for length at every visit. Complete physical review of systems and any indicated labs should be done. You want to get as detailed history as possible. If a child is above the 95th percentile or crossing percentiles, you want to know what's the family history, the parental history of obesity, what's going on at home, the social environment, a very detailed daily feeding activity and sleep routine history. What about breastfeeding, formula, food preparation? What are the parents worried about? When in doubt, if you really get a kid who's gaining weight and you can't pin it down, you can bring the child in and watch the parents and the child interact around feeding in your office. After the first minute, they forget you're there, and you can really learn a lot. And involve everyone who cares for the child in this feeding, in your attempt to understand what is really going on with feeding. And I'm just going to end with this weight per length chart, which we have all seen, right? And as the child crossed percentiles between 2 months and 6 months, all those questions should be asked. And you can see that 2 months and 6 months still on the growth chart, but by 16 months above, right? And now things have escalated. So as soon as you see this liftoff, you need to just start asking questions, because what you really want to do is return that child to normal feeding and activity practices. You don't need to do anything dramatic, but often you'll find all those risk factors we talked about, some of them operating in this situation. So I'm going to end here, and I'll be glad to take questions.
Thank you so much, Dr. Hassink. That was a wonderful talk. That is one of my favorite topics in pediatrics. I know, because, you know, we do it every day, and, you know, a lot of days it feels like we are fighting a losing battle, but every now and then you get that parent who just gets it, and they actually take your advice and do what you tell them. And then, you know, you feel like, okay, I can keep going. I can keep fighting this battle. So thank you for just reaffirming all of that, and, you know, making me realize that I am doing the right thing with the education that I provide to parents. So it looks like we do have a couple of questions here. Elizabeth, do you want to do the questions?
Yeah, I'll go ahead.
Instead of feeding is very important. Responsive feeding is also really important. So if responsive, and we know responsive feeding mitigates some of those obesity risk factors. So I think that I don't know enough about BabyWise to know what the data is. My guess is that originated because of some of the sort of difficulty families have in getting in any kind of a routine. And it's really a balance between routine and responsiveness, right? So responding to hunger and satiety cues, but yet having a good sleep plan, so the child has a sleep schedule and a sleep routine. So I'd have to look into it, but I think the combination of those is important.
Next question. What do you think about pureed foods in pouches as an on-the-go snack for toddlers?
I think you can really understand the appeal of this. It's neat, it's convenient, it's on the go. However, it sort of bypasses normal chewing and texture of food. And there's some dentists that are actually concerned about this because of chewing and using your muscles helps form your mouth. And so they're seeing some more malocclusions because of the bypassing of the chewing. And also I think it bypasses satiety. It's almost like beverages, sometimes it's harder to feel satiated with beverages than when you have fiber in the food. So I understand why parents use it, and I think that helping parents understand what toddler foods can be that they could do at home is where we need to go with this. Not denigrate the parent for using it, understand why, but they need to have access to information about convenient finger foods that they can do at home for toddlers that are safe.
Next question. How do you obtain family history when the mom and dad are clearly obese?
You know, the obesity is not a secret. You know, if you struggle with your weight, you know. So you can, when you ask parents, are they concerned about weight in their child, I would start there. Often they'll say yes, because we have struggled. You know, you don't have to go right at them around their obesity. The other way you can do it, if it seems uncomfortable, is just to start asking about the obesity-related comorbidities, problems with diabetes, with liver, with sleep apnea. Often that helps them feel like, okay, this is going to be medical, right? It's not just about my weight. The doctor's concerned about the family history of medical problems. And then you can make the connection around obesity. So I think there are some other ways to get at that if the parents and you are feeling uncomfortable about it.
Okay. So we have 2 more questions and then we'll move on. So WIC and the unhealthy food that they cover, what's being done?
Was that about WIC?
Yeah. Like
yeah,
juice
yeah.
coverage.
We talked, I think we talk nationally. Of course, everybody talks to their state WIC. It's very hard for WIC because juice is considered a vitamin C, the way they provide vitamin C, and they get concerned about fresh produce and the ability of the families to access that. It's an ongoing discussion. I think that one thing you can do on our side as clinicians is to make sure the family, if they're in WIC, has access to enough access to fresh produce and ways to get fruits and vegetables into the diet. So often access to other sources of food like food pantries. We talk to WIC all the time about this, and it's hard because they feel obligated to provide that vitamin C requirement and somewhat constrained about how to do it. But yes, it's a problem.
Okay, last question. How do you change the concept of that a chubby baby or child is a healthy child?
That is really hard, and it varies culturally. You know, in our human history, a chubby baby was a healthy child because diarrheal diseases were major killers of babies, and a chubby baby would withstand that more. So over time, that was a sign of health. I think reassurance, just reassurance to the parents that the baby is healthy and growing well. You can use the growth chart, although parents sometimes have trouble understanding how that relates to their child. Going over feeding, and when you do a feeding history and just reassuring the mom that this is fine, the baby doesn't need more food. I think reassurance. It's awfully hard sometimes to move that dial, but reassurance is what I would do here.
All right, thank you.
Thank you.
Awesome. Thank you so much, Dr. Hassink. We really appreciate you being here, and I think we will hear from Dr. Hassink again in just a little bit. So right over to Dr. Hassink.
Thank you. Okay. Let me just see here. All right. So we're going to regroup a little bit and think about our patient encounter with the families and children we see. I have nothing to disclose. And what we all want is an optimal patient encounter. And sometimes some things can get in the way of having the kind of encounter we want. So we're going to be talking about weight bias, how to enhance our encounter with motivational interviewing, and if we have some time, exploring a little bit about mindfulness in the patient encounter. So we know that every encounter is an opportunity. If we always do what we've always done, we'll always get what we've always got. And life is all about change. So I think we're always thinking about our patient encounter and how we can improve our interactions with our patients. And especially in an age where relational and social determinants of health are at the root of so much of childhood and adult morbidity, the possibility of the patient encounter to reveal and hold these experiences in a safe space and to foster healing and hope is incalculable. And I want you to think about how important you all are in terms of the kinds of relationships you have with patients and families and the kind of healing that can take place in an encounter and the building of a relationship. But we are busy people. So in the patient encounter, we have patient concerns, patient history. We have to do a review of symptoms, physical exam. We have guidelines and quality metrics to fulfill. We have to document. We have to diagnose and prescribe treatment. And we're in many roles in the encounter. We're an expert in child health. We're a treatment provider. We're the link often to the healthcare system. We're diagnosticians, partners, agents of change, but we're also healers. So the patient encounter is the place where a lot of our important work occurs, and we can all think back and think what makes a really optimal or really good patient encounter, and what influences the quality of that encounter, what are the outcomes, and how can we make this encounter more meaningful and move our patients toward healing and health. So there are many descriptions of patient encounters, a safe place where patients can regain or maintain a sense of integrity and wholeness. It's more than a place, it's an experience that involves a meaningful exchange between ourselves and our patients. The link between effective physician-patient communication and patient health outcomes is well recognized in the literature. Improved emotional health, symptom resolution, functional status, and pain control. And for optimal communication to occur, we have to be mindful of what's happening in the encounter. And sometimes this often requires openness, courage, our immediate presence and availability to the patient. So what happens with patients with obesity? We want to be free, or at least recognize the effect of weight bias. And weight bias affects the clinical environment. It can affect the child's feelings about themselves, healthcare providers, and can influence their approach to care. It can affect their own health. It can affect the family and their approach to the child, and our own approach to the patient and delivery of care. So the AAP has a policy on stigma experienced by children and adolescents with obesity, and weight stigma is primarily expressed as weight-based victimization, teasing, and bullying. There's weight stigma by parents, family members, teachers, healthcare professionals, society at large, including the media. This is not a surprise, but we know it starts early. So negative weight-based stereotypes can emerge as young as 3 years old. Adolescents report the primary reason their peers are teased or bullied at school is because of their weight. And 71% of adolescents seeking weight treatment reported being bullied about their weight in the past year. And more than 1/3 indicated that bullying had persisted for more than 5 years. This increases vulnerability in the child to depression, anxiety, substance abuse, low self-esteem, poor body image, and self-harm behaviors and suicidality are higher among youth who have been teased or bullied about their weight. So what is weight bias? Negative weight-related attitudes, beliefs, assumptions, and judgments toward individuals who have overweight or obesity. So it can involve prejudice, personal attitudes toward patients, stereotypes, beliefs that patients with overweight and obesity are lacking willpower, are lazy or non-compliant with treatment, and lack the self-discipline to improve their health, and ultimately result in discrimination with unfair and unequitable treatment of patients with overweight and obesity. What happens in clinical care? Studies show that physicians who hold negative attitudes and stereotypes about patients with obesity view them as less compliant and less motivated, less disciplined, less adherent to medications, less trustworthy, and more annoying. Additionally, as the patient's BMI increases, physicians report less patience, less desire to help the patient, less respect for the patient, and greater perception of the patient as a waste of time. And weight bias is as common in the healthcare settings as it is in the general population, and it's independent of our own weight and gender. And it can affect the delivery and quality of care that we give our patients. The patients experience this bias and get discouraged about making the positive lifestyle changes we want them to make. They can avoid seeking routine or preventive care and engage in unhealthy weight control behaviors and experience the negative psychological consequences of weight bias, but it can be reduced. So how can it be reduced? We can be aware of our own attitudes about body weight, and we can, in that awareness, implement appropriate and sensitive communication strategies with patients who have overweight and obesity. So in clinical care, if we have negative weight-based assumptions, we can be treating the patient as if obesity is all about just self-discipline. If we have negative stereotypes, we can be thinking that our treatment isn't working just because the patient is lazy or lacks willpower or is non-compliant. Negative stereotypes come into play when in our terminology about patients with obesity, such as fat. And insensitive remarks or jokes can make the person with obesity the target of humor or ridicule. And when patients report about how they feel, they feel like they are being blamed for their weight and related problems. They are perceiving a lack of empathy from us. They feel as if they will not be taken seriously or being judged. They feel upset by comments about the weight. They are reluctant then to discuss their weight and weight-related concerns. So if your causal beliefs about obesity, if all of us think that it's just lack of self-discipline, poor eating and activity, that gives rise to reinforcing the negative stereotypes and stigma. But if we're aware of the biologic, genetic, and environmental causes, we get a greater understanding of the complex etiology of obesity. This reduces stigma. And toward our patients, this attitude of the complexity of the etiology of obesity reduces self-blame and increases self-efficacy for weight loss. So the AAP recommends that we are role models, we're supportive and non-biased. We work to dispel our own common stereotypes and recognize our own biases and don't act on them. We use appropriate word choices, weight and body mass index, and not obese, extremely obese, fat. Use people first language, such as a child with obesity, not an obese child, and advocate against weight stigma. And we want to create a safe and welcoming and non-stigmatizing clinical space that accommodates all of our patients of diverse body sizes. And we want to assess patients not only for physical, but also emotional comorbidities and negative exposures associated with weight, which we know occur, such as depression and anxiety. We use obesity as a medical diagnosis, but with our patients, where you want to use more neutral terms, such as unhealthy weight. We use patient-centered, empathic behavior change approaches, such as motivational interviewing, and we want to collaborate with our patients in determining their goals as partners. Modeling in the office, we want to have healthy books, posters, and videos in our waiting room promoting a healthy lifestyle. Staff can model what they eat and drink in the office. We can have appropriate gown, seating, and equipment, sensitive procedures for checking weight, and consistent messages, and work with the community to share these messages. This is just a poster that just shows the highlights from our policy about stigma. Importantly, I want to point out that there are physiologic effects of weight stigma. So with increased weight discrimination that is experienced by the patient, this causes a stress response, increased C-reactive protein, blood pressure, cortisol, hemoglobin A1C, increases the risk of cardiovascular disease and metabolic and endocrine disorders. So this isn't just about feelings and terms. This is about these feelings, these biases and stigmas as experienced cause real physiologic damage and negative change for our patients. So the effects of weight bias can have negative consequences across multiple domains of life. Patients don't want to come back to the healthcare system. They're biased, so they don't get jobs at the same level as their normal weight peers. It has a harmful impact on physiology, elevated risk for disease, diminished social support, poor recovery from disease, and eventually increased morbidity and mortality. So I just show you this with the website at the bottom. This is the Blood Center, where you can take a quiz that shows if you have implicit bias to weight. This is embedded in our culture. We all have it. And in self-examination, you can recognize if you have it and just not act on it and be aware of the bias that is often expressed with our patients. So how do we move on and have an effective dialogue with our patients in the weight management encounter? We know that families influence our patients' ability to make change. Patients are embedded in the culture, environment, their effect of their own personality, their individual history and health, and families mediate those factors for children. Traditionally, psychotherapeutic techniques have been physician-driven. Then we moved to physician coaching of parents with parent participation. Then we moved to social learning theory, where we thought, well, we change a parent's behavior leads to a change in child behavior, and an adult education model where parents were active participants, and that had a positive result in child weight control. So the more you partner, the better with the parents and family and patient, the better this gets. But we're kind of taught to give advice regarding the medical implications of the behavior. We want to suggest things families can do and share information. So that's all good, but what do you do when your family is ambivalent about changing behavior? So when we have an ambivalent patient who's unsure and trying to make change but isn't sure, unwelcome advice can elicit resistance. Knowledge is weakly correlated with behavior. There is variability and personal motivation, and we have to match the patient's motivation and get in sync with the patient to make change. So ambivalence is considered a normal phase in the behavior change process rather than an obstacle. And patients are encouraged to express the pros and cons of making a change and the difficulties, barriers, and facilitators. And we want to be non-judgmental, empathic, and encouraging during this process. And this technique of motivational interviewing was really derived from Rolnick and Milner's motivational change work in substance abuse and rolled into many other phases of medicine. So again, traditional counseling relied on our insights about the patient. Traditional nutrition and activity counseling revolved around us thinking, well, if I just give the patient enough information, they'll do it. But motivational interviewing really is interactive. Patients are doing most of the work of change, and it assumes behavioral change is driven more by motivation than by information, and that information is necessary but not sufficient. So the following will be a review for those of you who are using motivational change. I hope you'll just brush up on it for your clinic, and for those of you who are new to it, hopefully it'll get you interested. So it's not arguing a person has a problem and needs a change. It's not offering advice without a patient's permission. Can often be difficult when you first start asking a patient, can we talk about something? Not taking an expert stance, although all our expert knowledge is still with us and we use it during the course of the evaluation, and not doing most of the talking. So we want to express empathy. To a mom who's frustrated about cooking when the children complain about a healthy meal, I understand that you must feel hurt when children complain about having the healthy meal you've worked so hard to cook. It involves developing discrepancy between what's happening and what they want to happen. Sam enjoys exercise before bedtime, but his sleep apnea is getting worse because of his extra weight. Here we have a discrepancy, moving the patient along to what might we do about that. Avoiding argumentation and defending because that breeds defensiveness. When the patient seems to be resistant or having resistance, it's a signal to change your strategy. So having your child inside and playing video games works well for your family. So me pushing about stopping that, the mother is resistant to that change. So I say, it seems to work well. Do you see anything that might not work as well out of this? You may have to change tactics and aim at another goal that seems more motivating to the parent. And supporting self-efficacy. It's great that you and your family made a plan that worked to limit screen time and reinforce completed goals every time. There are skills, and this is a toolbox for you. You don't necessarily use all of these every visit, but these are tools in your toolbox that you pull out to help the visit with the patient move along toward change. So we want to establish rapport with the patient. We use our body language. We talked about weight bias and stigma. We want to listen, express empathy, try not to hurry, sit down, be patient, and express your genuine interest in the patient. You have to gather background information about history, social determinants, review of systems, physical exam, and you have to be in your mind assessing risk-based priorities, comorbidities of obesity. That is work you still have to do. But you also want to establish a partnership of care. Can we talk together about some ways to help Kim with her concerns about her weight? Asking permission. When somebody says yes to that, they will often be more receptive to the next part of the conversation if you ask. It can feel awkward at first, but it's very helpful. Joining forces. Would you like to hear about some ways other families have tried to limit screen time? Often referring to other things people have tried opens the door for the patient to say, yeah, I could hear about that. And then moving on. Can we talk about John's reluctance to exercise on his next visit? Would you be willing to do that? You want to be thinking about open-ended questions, which puts the ball in motion. These are questions that are not yes or no questions. They use the patient's own words, and they're not biased. So to what extent does Sally's lack of exercise seem to bother you? You seem bothered. Do you want to talk about it? Not how often, why? Tell me about that. Help me understand. What if? What else could happen? Not did you, will you, can you, is it? These are classic closed questions, and it answered yes or no and stops the conversation. So some open-ended questions might be, are you comfortable not asking your child to finish what's on her plate? Will not buying sodas increase the amount of stress in your house? Do you think you will be able to reduce the amount of TV your son watches? Classic one, will your husband go along with these changes? Can you start to make these changes in the next week? All of these allow for the conversational ball to keep rolling. There's no right or wrong here. You just want the conversation to keep going and to move toward change conversation by the patient. So the other technique that can be very helpful here is reflective listening. You want to keep the ball rolling. This involves restating and rephrasing what the patient told you, and that tells them that you have heard them, that you are listening. It can often clarify meaning and build rapport. So to give a reflection, the parent tells you something about the child that maybe they're unhappy with, and you say, it sounds like you're feeling unhappy that John refuses to eat his vegetables. Sometimes you can say you're not ready to. I prefer, it sounds like you are feeling, it sounds like this, because it doesn't assume anything. They'll correct you if you're wrong. If you say it sounds like you're feeling unhappy, if they're not unhappy, they're going to say, no, it really doesn't bother me, and you'll move on to the next thing. But reflecting things signals to the patient, I have heard you. So the mother might say, or father, I want my son to lose weight because I don't want him to have my health problems. And you can reflect just the content you heard. You see a connection between weight gain and health problems. You seem to see one. And they'll say, yeah, I have diabetes, and so on. If you hear feeling in the patient's statement and you're resonating with that, you can say in response to this, it sounds like you're afraid your son might have health problems as a result of the weight. You're afraid. And you might even say, it sounds like it seems your son's very important to you and you want him to be healthy. All of these elicit comment from the patient and move them toward change talk about what they would desire and what they want. So a parent may say to you, I know TV is bad for Jimmy, but I need some peace and quiet in the house. I'm a single mom. I don't have a lot of help. Having him watch TV lets me get my housework and schoolwork done. He is happy and content, and frankly, I don't have to worry about entertaining him. So this is what you're told, and you might choose any one of these reflections would keep the ball rolling. It sounds like letting him watch TV, it gives you time to get your work done. Or it sounds like it's exhausting to have to entertain him all the time. Sounds like you would like for him to watch less TV. Sounds like you don't have to worry about him when he's watching TV. Or you could maybe bring forth some ambivalence. On the one hand, you need some free time to get things done, but on the other hand, it sounds like you're concerned about the amount of time he spends watching TV. Again, the point of this is to open up the dialogue and get the patient to move their conversation from the problem to the change. So when you reflect back content, you reflect back what the parent just told you, what their specific concerns are, how they might want to guide how you might want to guide the conversation. And maybe in reflecting it back, it might open up that they need some more information about what they're trying to do. When you reflect back feelings, you're trying to elicit what feelings are driving the behavior. I'm frustrated, I'm angry, I'm upset, I'm worried. What feelings could enable change? Often feelings are the motivators toward change, but what feelings could impede change? So you're trying to open up that part of the dialogue. And then meaning. What does this mean to the mother that her child is refusing food? Maybe she grew up hungry and she just can't imagine how a child could refuse food. It might open up what the parent values, family meals. I want my family to be together more. What does it say about the family dynamics? Sometimes courtesy of my friend Bob Schwartz, he often carried this card around with him and gave it to parents and said, while you're waiting, could you just fill this out? Things that are important to you about your child, about values for you, about your family, just to get a feel for where are the parents? What do they desire? The child, does he want to be strong because he wants to play a sport? The parent, I want to be respected at home and not talked back to and ignored by my kids. What I want the family to spend time together. These give you clues as to what the motivators are here for the patient, and sometimes that can be a good tool. When you provide information, you want to often ask, do you mind if would you like to hear more about sugared beverages? Do you mind if we talk about what other families do? Would you like that about watching TV? This statement's very powerful, and when patients say yes, they're more likely to receive the information. You might want to list the pros and cons. Could you tell me some things that you like about convenience food and fast food meals. What might not be so good about that? Is there any reason you would like to change that? You can elicit the pros and cons. This is another one that is useful, but sometimes awkward when you first start to do it. It's eliciting how important this change might be to you and how confident are you that you can do it. And there's actually, people can use scales. And I'll give you an example of that here. It sounds like you're concerned about Alice's health and her grandmother's comments. And mom said, yeah, I'm worried about Alice's self-esteem. I was heavy as a child and I don't want Alice going through that. Well, where does this leave you? Well, I think if Alice could get more active, that would help her weight. Now, you want to assess importance and confidence to see where the patient is. So how important do you think it is for you to have Alice increase her exercise? On a scale of 1 to 10, 10 being the most important, where do you think you are? Well, I think I'm about an 8. And then you can ask, what makes you an 8 and not a 10? And the mother might say, well, I have a hard time. I work long. I can't get Alice out. But what is it that makes you an 8 and not a 4? Well, my husband's very supportive of me, and I think I really could get this done. And then how confident are you that Alice will be able to increase her exercise? I think about a 4. What is it that makes you a 4 and not a 7? Well, Alice just doesn't want to get off her screens, and I have trouble motivating her. But what makes you a 4 and not a 2? Well, I really feel that she does like walking with me, and so that can be a possibility for us. So this is a conversation you have where you really troubleshoot what patients want to do before they do it, to sort of be able to talk about some of the barriers and facilitators. And at the end, of course, you want to just wrap up what happened. So if they're not ready to change, you can say, perhaps we can discuss it at the next visit. So you don't drop the patient. You just, they're not ready to change, keep them in the train. Next visit, can we talk about some things? And Change Talk, the app I talked about before, is a great little intro to motivational interviewing and a great practice for you. So the basic concepts of MI are that the patient rather than the clinician should make the argument for change. You're trying to get the words for change out of the patient's mouth. You're trying to evoke their own concerns and motivation and listen with empathy, minimize resistance, and nurture their hope and optimism that, yeah, we can get this done. So in the last bit of our conversation, I wanted to talk about the role of mindfulness in the patient encounter. You can see that we're trying to move toward a more and more effective patient encounter, and how can we do that? So we know that patient-physician communication, health provider communication really affects patient health outcomes in a positive way. And Stuart would say that to do that, we have to be mindful of what's happening in the encounter, what our communication is like, what our attitudes are like. We want to be non-judgmental if we're mindful. And when we be open to the whole person, free of our judgments, our preconceived notions, and we want to, the goal of being open, the goal of being mindful of what's going on is to come up with informed, compassionate action that incorporates the relevant information that results in correct decisions and relieves the patient's suffering or moves the patient toward health. So mindful meditation practice has been used with healthcare workers to help them become more mindful in the clinical situation. And evidence suggests that mindfulness meditation is associated with physiologic change and optimizes our ability to process information. And who doesn't want that? So since 1978, over 30 empirical studies have been published on the use of mindfulness-based interventions with healthcare professionals. And outcomes have shown improvements in burnout and job engagement, distress tolerance, active listening and empathy, and non-judgmental self-reflection and self-compassion. And so there are mechanisms involved in mindfulness meditation: attention regulation, body awareness, emotional regulation, change in self-perspective. These are mechanisms that really work when you do mindful meditation to improve these things. You could say maybe the opposite of mindfulness is mindlessness, and it's more likely when people are distracted, hurried, or overloaded. Well, that describes everybody. And to deal with production pressures, people can often ignore clues or cut corners in their attention and what information they're able to process. Mindlessness also occurs when we feel we can't act upon our concern. We're powerless, and so we're not then attending to all the clues and all the subtleties of the interaction. We filter lots of information every day, and every observation is preceded by a choice of what to observe and what not to observe. And we often find what we're looking for, but we can often miss out on much more. So it takes a lot of data processing to figure out what's happening to the patient, where the patient is, and how to help the patient. So these are learned mental habits of attention, observation of self, the patient, the context, and really invokes viewing the situation free of preconceptions and being present to that situation. So WellMD at Stanford Med endorses mindfulness, a process that helps enhance focus and clarity, helps physicians and staff listen more carefully to patients, show more compassion, especially suited for primary care clinicians because it can counteract our capacity to worry and have perfectionism and negative self-judgment, neutralizes power of regrets from past and fear of the future, and enhances well-being. So clearly this healthcare system has endorsed this as a good practice. And we don't see things as they are, we see things as we are. So if we step in a room preoccupied and hurried and we're worried, we may not see things the same way as when we step into that room and we are calm and we are present to the patient. So reported benefits of mindfulness training by practitioners: I'm able to be fully attentive to a conversation. I'm able to make time most days to prioritize my work. I'm able to notice when my attention has been pulled away and redirected to the present. I'm able to say no and set boundaries with ease and grace, less harshness and less guilt. After mindfulness training, 93% of physicians reported I'm now taking more time to reflect. My listening is better, my patience is better, I feel more clear. So these have real benefits when we're trying to approach each patient with that clarity of mind to help them move toward change and health. And these are just some quotes from people, and you can read these in your slide set, but I'm definitely integrating mindfulness when I'm meeting with someone at work. I really focus on being attentive to the conversation, and I really feel like I have connected more with people than I ever have. And connection at this particular time is more important than ever. Every interaction is an opportunity for connection. This is a little bit of mindful practice, and I won't do it here, but often one of the simplest ways to practice mindfulness is just to sit comfortably with your eyes closed. Just direct your attention to your breathing. When thoughts and feelings come into your mind, don't actively just let them go, accept them. They'll come, they'll go, don't judge them, don't try to work the problem. If your attention drifts, just come back to your breathing and do this for 10 minutes. This is sort of the opposite of the stress response. This invokes a response in your body that is a relaxation response. It improves your clarity, and it's just a simple way to focus on. The reason you focus on your breathing is just to allow yourself to have something to focus on and let the thoughts just come and go, and not grab onto those thoughts and work them mentally. So 10 minutes every day is a nice mindfulness practice. There are also ways to incorporate mindfulness in your living. Take a few minutes in the morning to be quiet and still, and I mean a few minutes. It doesn't take long. Be with yourself for 2 minutes. Gaze out of the window for a minute. Listen to the birds singing. Take a little walk. Mindful eating has been often used as in conjunction with obesity treatment. Taste your food. Give your food your attention. Don't answer your mail while you're eating. Don't watch TV. Just be present to that experience. We can pay attention to the movement of our body when we're walking. You're walking from one place to another, just pay attention to the walking itself. We can pay attention to our morning routines. Just be in the routine. Don't start thinking through your task list of the day. And if you do, let those thoughts just come and go. Give yourself permission to be in the moment. And then sitting at a red light, instead of checking your email, just breathe a little bit. For busy physicians, when our pagers or phones ring, take a couple breaths before you answer. When you enter the exam room, take a couple deep breaths. Get your mind maybe a little settled. Eating, walking, gratitude comes into this. Trying to be grateful for something, because that can help balance the critical views we often have of what we didn't do, what's not happening. Pay attention when you're driving home. And some people, and smiling activates positive biochemistry. So mindfulness can help bring us into the present. It's the opposite of multitasking. And if you try this, clearing your mind, taking a few deep breaths before you walk in with a patient, you can see how you like it and how it works. So Steve Carey's from New Jersey would say that primary care, I don't know if I'd use the word chaos, he certainly does. There's a lot going on. You can see it there: decision-making, isolation, uncertainty, time, revenue. It can be repetitive. Being mindful allows you to be in the present. It encourages reflectivity and helps you take care of this. You can also be mindful of your clinical environment. Take a moment and put yourself in the place of your patients. Walk to the front desk, down the hall, into the exam room, and see what you see and hear, and see how it makes you feel. So when we first moved into our clinic space for weight management, we didn't use good scale etiquette. We had small tables and chairs. We had pictures on the wall that weren't calming. We had noise in the hall. We had food everywhere that we had to pay attention to for our patients. So before entering the room, take a breath. Focus on your breath. Be mindful of the present moment. Try to get into a non-judgmental state about what you're going to see in that room. Spend a moment to greet the patient. As you begin listening, try to focus on the patient. If you get distracted, return to the patient as you would return to your breath during practice. Be mindful of the power of gentleness as you examine the patient. Wait at the end in a small moment of silence for whatever else may arise, because often that's when the patient wants to tell you something important. And at the end of the visit, take a breath and experience compassion for yourself and for your patient and what's happened there, and the love and empathy that you were able to show your patient. In the last minute or two, is there a way to practice mindfulness in the moment in the clinical encounter? These are a few clinical vignettes. A mom was trying to breastfeed her baby with Prader-Willi syndrome, who had a history of hypertonia. She had a history of difficult and painful breastfeeding. She wanted to resume breastfeeding. We taught her some breathing techniques before the baby latched on. She was able to calm down. The baby was improving because of his early therapy for PWS, and she was able to return to nursing her baby. A teen with ADD was having a hard time in school, failing subjects, anxious about the end of year testing. Her weight was going up. She said, "I'm not paying attention to what I'm eating." Discussed with her about anxiety and her mind needing a rest. We tried some breathing. She said it was right in clinic. She said it was a relief to let those thoughts go as she was breathing. And she thought she might try this before she did her homework. We also could have talked about mindful eating in this scenario. And a 14-year-old boy with Asperger's syndrome, they would walk into clinic so anxious, they would have trouble focusing on what was happening. There was some arguing. They were willing when I asked to try breathing in the moment. Just before we started, they did, and we were able to sort of proceed with the visit, and they felt calmer. So we can influence the interaction that we have with patients and the character of our relationships through our behavior in the encounter. And this is one of our gifts and one of our opportunities. So I think I will just talk about presence, and it's a connection that we make between ourselves and the patient when we have undistracted attention on our task and compassion based on our insight from that patient. And connection is the goal here, to connect with our patients. This helps us generate inner strength and to move on and do the hard work of healing and healthcare. So both of us are affected in the patient encounter. To be present is to be close to ourselves, but also close to the other. And to be available is to be uncluttered by a sense of our own importance, so unthreatened by the strangeness of the other that one may enter immediately into communion. And this is a patient experience. It's the quietness from me that makes others trust in me. I'm in a physician experience, I'm sorry. It's the quietness in me that makes others trust in me. I show that I have time to be with you now without any explanations. To make myself available in the encounter has to do with being quiet within oneself. I have to show I can sit here, even though there is hurry in other places, because I have chosen to sit by you. I do not need to say this, because I show it in the way that I am. And I think I'll stop there for questions.
Thank you so much, Dr. Hassink. That was another wonderful talk. And I think it's great that we're all reminded of the importance of considering our own thoughts and feelings when we're dealing with our patients, especially when we're talking about a sensitive issue like obesity and eating and exercise habits. If Dr. Custodio is on here, maybe we can have mindfulness training as part of our next meeting. Dr. Dawson, do we have any questions in our Q&A box? All right. All right. I don't think we have any questions. So I appreciate your time, Dr. Hassink. We're really honored to have you here with us today. And I really appreciate all of the information that you shared with us. I know it's going to be very useful for those of us going back into our practices this week. So thank you for being with us, and I hope you have a wonderful rest of your weekend.
Well, my pleasure, and my regards to all the members of your wonderful chapter.
Thank you so much. All right. At this time, I'll take a minute to acknowledge all of our sponsors who have helped make today's event possible. We are appreciative of their support for helping us to transition to a virtual event, and we're thankful for them for sticking with us through that. So at this time, I'm going to ask Kaysen Benton to join me, and she is going to talk with us briefly about the Alabama Child Health Improvement Alliance's 2021 Pediatric Obesity Quality Improvement Collaborative. So if Dr. Benton is on the line, there she is. All right, I'm going to turn it over to her for a second.
Hey, everybody. Gosh, and Dr. Hassink, thanks so much for kicking off our collaborative for the coming year. I think most of you on the line are aware of ACHIA, but just briefly, for those of you who are not, ACHIA, the Alabama Child Health Improvement Alliance, is a partnership of groups around the state that are interested in using quality improvement as a tool to improve optimal health outcomes for children in our state. And while it is a state organization, we partner with groups around the country, such as our mothership group, the National Improvement Partnership Network, and we also work very closely with other national groups interested in using improvement for health outcomes, such as Dr. Hassink's Institute for Healthy Weight and AAP, and we're very appreciative of them. But what we find is by using state-based initiatives, that really enhances our peer-to-peer learning, because we're learning from other practices in the state that are operating in our conditions, same incentives from payers, same drivers, and we really learn a lot from one another. In addition, we provide lots of things that are important for practices to function, such as being sure you get your MOC for your board certification, helping support your CME for your license, and increasingly meeting your patient-centered medical home requirements, which are great for our practice to be and also will often align with incentives from payers. So as Dr. Skinner mentioned, we are doing obesity prevention for the coming year, and we'll be modeling our collaborative on a successful one that the Academy has put together. And we'll be addressing the complex issues, but of course you in your practice will be able to focus on the areas that you think will have the highest yield and impact within your practice. We're also putting together this fun patient education toolkit that has the measuring cups and the spoons and some pictures and focuses on portion control. For those of you who have participated in collaboratives before, there are a few changes that I want you to be aware of. The first is we're kicking it off earlier this year. The kickoff is in December, not our traditional January. We are trialing fewer months of data collection, so we're hoping that that will make it easier for people to participate without limiting the impact and information you need to bring changes to your practice. And then lastly, for the first time, we are limiting enrollment. So it will be a first come, first serve, and it won't just be, you know, anybody coming in. So if you think this is something you're interested in, please let us know. As usual, there are no charges, but there is a time commitment to participating in QI. And we are helping, my colleague Linda Champion, our QI coach Lucretia Thomas, we're happy to talk to you about what that time commitment looks like and help you figure out if it's a good year for you to participate in a collaborative. So with that in mind, you can see how to contact us. Linda Champion, lchampion at alaap.org, or I imagine it would be fine also just to indicate your interest in the chat box, and we can grab that information from there as well, and we'll get an email out to you. So that is our Healthy Beginnings, but I also have a request of you. As I mentioned, ACHIA is a partnership, and the providers are obviously a key partner in what we do. And the way we like to choose our topics for what we're going to focus on is we solicit feedback from you, from payers, from our community organizations. And what we're really looking for is where are our opportunities to align our efforts so that the work you're doing in your practice fits well with other incentives and activities that are happening across the state. And so it is time for us to start looking into our topics for the next 3 to 5 years. So I'm going to ask you guys to participate in a poll, which is about to come out. And this is a poll for providers, nurse practitioners. If there are any practice managers on the phone, you're welcome to participate as well. And what we're looking for is, let me just see, can we move over to that poll? Just double checking that that's going to be pulling up now. I think I saw it. It's about to come up. So before you start marking the answers, this is a poll, and what I want you to think in your mind is what topics do you find clinically engaging? Where do you want the opportunity, the time, the space to improve your office systems? Because this is much more than just what you as a provider do in the room. This is about how your whole office approaches a certain area. And, you know, honestly, what do you think would help your bottom line too? Are there any of these? And so what I want you to do is check as many topics as you think you could consider being valuable to you or to your practice. And do scroll down. There are a couple that aren't on the screen. And then unfortunately, I was not able to have an open thing for you to type in additional areas that you would like to see addressed that I didn't put a multiple choice for. So if there's something on here that you would like to see a collaborative for, please either type it into the chat box, or again, you can email myself or Linda Champion, and that would be helpful as well. So with that, let me just give you an opportunity, a few seconds here, to mark the ones you are interested in. And then we'll, after a few 10, 15 seconds, we'll close the poll and see what we got. And I'll just list them while you are marking. I'll read them out. Our early screening collaborative is always popular. We have moved towards focusing on development, autism, postpartum screening, and depression, usually letting practices focus on one of those to improve. We're doing obesity prevention in the coming year, but we have done obesity prevention and treatment in the past. Dental screening, there's an awesome collaborative available through the Academy, but would you like to see that in a collaborative setting? Transitioning from to adult care, we had a little bit of that in our adolescent collaborative, but that's an opportunity to expand. Depression screening, substance use and abuse, focusing more on social determinants of health, ACEs, trauma-informed care, asthma management, ADHD management, and increasing our immunization rates. So with that, I think you guys have probably had enough time to consider your options. And can we go ahead and close the poll out and see what people were interested in? All right. Oh gosh. Okay. Boy, we have a lot of interest in our state. So that's depression seems to be at the top. So that is one that, thank you for sharing that. And early screening, obesity prevention and treatment, awesome. I hope you're interested in what we're doing next year. It's going to be really good. Transition, the social emotional skill, and of course you guys know we have a leading national expert here in the state with Dr. Dawson. ADHD, very popular. Well, excellent. I really appreciate you guys sharing these insights, and if you have any thoughts afterwards, please just reach out to me, and thank you for your time. And Dr. Hassink, thank you so much. That was a phenomenal kickoff, and we really appreciate it.
Thank you, Dr. Benton. All right, I know these QI projects are always so rewarding, and I hope that we'll have a lot of practices that decide to participate in this one. All right, so we have our Reach Out and Read video ready now. So the one that we were supposed to show during the break, we're going to go ahead and play quickly for you now. So if our technical assistants will get that pulled up for us, we'll move to that quickly. While they're doing that, I'll just quickly tell you that we have